Welcome, everyone. So glad that you're back with us today. We have a very exciting and important conversation today about our seniors. We're all going to be seniors if we're lucky. And what is our system, and how is our system working, and how is it serving us as minorities in particular? I am Dr. Carlisle's Special Assistant for Community Affairs, and we're going to be talking about aging and elder care in diverse communities and the unique challenges being faced by older adults in minority communities, including access to senior care and supportive services. We have assembled an amazing panel of experts for today. Each has his or her own perspective to contribute to the discussion. Joining us today is Dr. Adrienne Mims, a 1985 alumni of the Family Medicine Residency Program at MLK and Charles R. Drew Medical Center. She is currently the Chief Medical Officer at Rainmaker Strategic Solutions, LLC, where she collaborates with members of various teams of professionals to expand Rainmaker's excellent healthcare industry reputation. Dr. Mims has extensive clinical practice experience in value-based care for adults and seniors, and she recently shared her expertise with GenCare Senior Medical Center, a healthcare system focusing on personalized quality care for vulnerable residents of Georgia. Welcome, Dr. Mims. We are also joined by longtime community advocate Veronica Moore. She is the Inflation Reduction Act Regional Lead for Medicare and Medicaid Services, where she conducts outreach, education on issues impacting underserved and underrepresented communities like ours. The issues impacting those communities include inflation, the Inflation Reduction Act, maternal health disparities, behavioral health, as well. She's working on improving overall health equity and access. So welcome, Mrs. Moore. Our esteemed third guest is our own David Carlisle, Dr. David Carlisle, who has been President and CEO of CDU for 14 years, which is really quite amazing because the average tenure of our presidents at Drew has been only 4 years before Dr. Carlisle. And in most colleges, it's 7 years. And he has been with us leading the way for so many wonderful new improvements for 14 years. So we're very grateful for his leadership here and for his involvement today in our discussion. He is a board certified internal medicine specialist and has served as director of the Office of Statewide Health Planning and Development for California. And he was there for 11 years. So he's somebody who stays a long time and does wonderful work. Thank you, those in the audience, for joining us. We have some questions to get started, and if time allows, we will be taking questions from you in the audience before we wrap up. So if you have a question, jot it down so we can get you if we can. Our attendees can ask their questions in the chat or tweet them with the hashtag, quote, CDU Community Forum, end quote, one word, CDU Community Forum. Now, let me start with Dr. Mims. Your extensive experience in geriatrics and family medicine, with that, could you shed light on some of the unique challenges faced by older adults in communities of color when it comes to accessing senior care and supportive services? Dr. Mims.
Thank you, and thank you for having me today, and I appreciate the question. My perspective, maybe because I'm a family medicine physician, is that the entrance to healthcare should be through the primary care physician. But right now, we're experiencing a crisis in primary care. there has been a continued decline in the number of primary care clinicians per people in the US. And when we don't have access to primary care, we don't have people to serve in that role, to be the primary leader of the care team, to be able to coordinate the care among the many specialists, the pulmonologist, cardiologist, orthopedic surgeon. And it leaves the patient out there trying to negotiate and navigate the healthcare system on their own, and that's a challenge. In our society that's rapidly aging and our older adults with multiple comorbid conditions at the same time, it's helpful to have a stable relationship with your primary care physician, somebody who knows you, someone who remembers your history, remembers your preferences. But in our current crisis, there are not enough, especially in our communities of color, people who look like them and can really relate to them. So, in my opinion, that is actually the biggest crisis. And if you're not in the community and you don't know the community resources and how to use them, it's hard to be very effective as an advisor to our patients and their loved ones when they're getting and accessing care. Thank you.
They need your guidance in what to do, where to go. It's not just obvious information. Mrs. Moore, your role involves conducting research and education on various health-related issues impacting underserved communities. Can you share with us some insights into the unique challenges faced by older adults in minority communities regarding access to Medicare and Medicaid services? Can't hear you. Wait, can't hear you.
May I mute myself? Just
There you
talking
go.
away. Thank you. The joys of technology, and that's going to lead me into what I was just about to say. I really appreciate the comments that Dr. Mims just provided, because she absolutely is correct, and we see the importance of particularly our older adults needing to have a healthcare home and that doctor that knows their history and all of the things that she talked about. But before they even can get to the doctor, one of the biggest challenges that I see, there are a few, is really related to when we're talking about the issues around health equity and access, right? I think we all can agree that, in today's age, for the most part, and there's still a lot of areas where it's not, but people can say, I have access because there's a doctor over here, there's a doctor there, there's a hospital here, there are all of these places and people that say that they can help me. But if I am a person who actually, I'll use it in the context of bicycles, right? If there are 4 people and 3 of them, all 4 have a bicycle, but one of them is in a wheelchair, the bicycle does them no good, right? So when we talk about the issue of equity and making sure that people really, really, truly understand, and when I say people, I mean those folks like myself, CMS, and other organizations that are really trying to serve patients and serve the community and older adults, how do we look at equity? And when we're talking about issues that are barriers for some of our older adults to even get to the doctor, we're talking about things like transportation, right? When we're looking at how to navigate Medicare and Medicaid programs, a lot of what happens in this space is, we've moved to, we're ever evolving in technology. So we're expecting our older adults now, they're saying, well, just go online and fill out this application. Or just, you can look it up on the internet. I was in the pharmacy about a month ago, and this gentleman was trying to get his medicine, and he was needing to get some kind of, I guess, what do you guys call it, where you can get a discount on your medicine. I don't know what the correct term is, but they were saying, well, you're going to have to go online. You're going to have to fill this out. You're going to have to send your email address. And this gentleman, he was like, I don't know how I'm going to be able to do all of that. Can somebody here help me with that? So I think that one of the barriers in terms of accessing even Medicare and Medicaid programs has to do with the ability for some of our older adults to navigate technology. And, we really need to have support systems and resources that are available that can help walk them through those processes, whether it's filling out the application online, filling out a hard copy of the application. That's one of the things that I see as a really big barrier for a lot of our older adults when we're talking about just getting in the door to apply for these programs. And then even understanding, the other piece is going to be information overload, right? You get our older adults get so much stuff in the mail. They're all, this company sent them this person called them on the phone and said, I got the best deal for you. So I think, for older adults to really be able to navigate all of the information that's coming at them, all of the different ways that they're told that they have to be able to access the information going online and things like that. I think those are some of the huge barriers that really create a lot of confusion. And it also causes a lot of our older adults to end up with, insurance plans that they didn't choose, losing their physicians because they didn't understand that, because I signed up for this and I'm going to lose my doctor I've been seeing for 20 years. So really the limited availability sometimes for them to be able to utilize technology in a way that is that's easy for them to navigate, as well as, making sure that they have access in this sense to organizations and people that can come in. Nothing replaces one-on-one help and assistance. So we do have the SHIP organizations, which are the senior health organizations, where they are based all around every state, where they can help people navigate these various, getting the applications in, making sure that they have the right resources, making sure they have the right information, knowing when, somebody is, trying to target them for Medicare or Medicaid fraud. So all of those things. So I just would say technology, as well as the ability to navigate this overload of information sometimes for these programs can be a struggle.
Well, the overload is universally experienced, but if you're a senior, it can really get in the way. Dr. Carlisle, could you share some insights into the specific barriers or systemic issues that contribute to disparities in access to quality elder care within communities of color?
Well, if there's one thing that the COVID-19 pandemic demonstrated, it's that African-American seniors constitute a very vulnerable population with disparate mortality during the pandemic. And I think that this just underscores lack of access for seniors. Seniors died disproportionately, often without seeing the doctor, because they had no access to the healthcare system. The healthcare system was not there for our seniors. What we see in South Los Angeles and communities like it throughout California or throughout the country is a lack of services. And whether it's a elder care, HMO, or other types of services, they're just not very prevalent in our under-resourced communities. And this does impact our African-American senior population, as we saw during the COVID-19 pandemic. It is an issue, and I think organizations are striving to make improvements, but it's why we use the term under-resourced community. It's because of the resources that are necessary to support our elder population are not present in our community to the extent that they are elsewhere. And we see this time and time again. People delaying healthcare, people that have no transportation to healthcare, people who are isolated, they remain homebound when there are all sorts of potential services that could be availed to them. So this is I think maybe a less recognized healthcare disparity, but it disproportionately loads on the African-American senior community, for sure.
And the result of that is more profound than it is for younger people, because the need is greater in many cases for our seniors to get that access. Dr. Mims, given your involvement in various healthcare organizations and initiatives focusing on equity in health, could you discuss some effective strategies or programs you've encountered that have successfully addressed the disparities that Dr. Carlisle is discussing in access to senior care among minority communities.
Yes, I'm happy to comment on that. I think that the recent move toward looking at a clinical practice as a whole population of patients has made a difference. Previously, the focus of the clinical care team is who's sitting right in front of me right now, who's the next patient on my schedule, and focusing on the best care I can give that person that I'm seeing. But now we're beginning to understand that each healthcare team has a population of patients that they see. Some come in regularly, and some you rarely or hardly ever see. But if you begin to look at it from a population approach and start to collect the data on your patient population, you can then begin to see there's these discrepancies. I may think everyone I'm taking care of has their blood pressure under control, but when I look at the whole roster, I suddenly find that there's a group of people who only come in when there's a crisis and don't keep those follow-up appointments. So as healthcare systems begin to collect their quality data and then stratify that data, stratify it by race, stratify it by insurance status, and begin to see the differences and find those outliers, and then have conversations with them to understand what the barriers are. It's not that people are non-compliant, it's that they're not able to conform to the care plan because of a barrier that needs to be uncovered. And as we uncover those barriers, we can then address them. In a local healthcare system, they found that the African American patient's blood pressure control was not as good as the rest of the population. And as they reached out, they realized it was a challenge in taking multiple medications many times a day. So they did an intervention combining two medications into one pill, mailing that to the people so they had it. They didn't have to go to the pharmacy to get it. And then scheduling nurse visits where a person can go in and get their blood pressure checked and not pay a copay or have a long wait to be seen. What they found in doing that is that a large number of the people whose blood pressure had not been measured or was not under control then became under control. So if you take the time to not just look at the measure of your performance, but to break it down and find out who is that subset of people who are not able to make the measure correct or not in compliance, as we call it. I think that we often feel that it is a lack of knowledge. Sometimes it is, but it's also priorities. And as we begin to look at the social and economic factors that control quality of care and health outcomes, we begin to look at, as was said before, transportation to the visit. We begin to look at the fact that our appointments are 9 to 5 Monday through Friday when a caregiver is not available to also attend. And so as we find out about those barriers for health equity, we can make adjustments and make care more accessible and convenient and eliminate some of those barriers. Thank you.
Well, it's a wonderful report of success, but I just wonder how broadly that success can be found, particularly in our low-income minority communities. It's just, it sounds like we found out what works, but can we get it in enough volume to the right places? Mrs. Moore, as a member of various health care related task forces and coalitions, could you speak to the importance of collaboration between government agencies, community organizations, and healthcare providers in providing access to senior care for minority populations?
Absolutely. So it's critically important that, particularly, I'm going to speak from the government space, being a government worker. There are a lot of policies and legislation and things that, that are proposed. And, sometimes it may feel like to the community that there is no public input on that, right? And the only way that the government is going to actually be able to really know what the needs are, what's important to our, particularly for our older adults, our senior populations, is to work collaboratively with all of those entities that work with our older adults and seniors on a regular basis. So it's very important for us to work with our faith community. It's very important for us to have conversations with our physicians and our hospitals, the health systems, the community health centers, because some of the things that you will see, Dr. Carlisle, Dr. Mims, that you would see in practice, at a community health center may be very different than what we're proposing in our policy or our legislation that doesn't match what the needs are. The other thing that I would say, in terms of looking at the different groups, it's not even only just making sure that we're working with our, healthcare providers, working with our faith community. We need to work with our business community as well. That's another component. Sometimes it gets left out because when we think about older adults or seniors, sometimes we think, everybody's retired and they're, resting at home and they've done their work. But the caregivers are a big component of that. So looking at, how do we even work with employers around policies and things like that, that can make sure that, people have adequate opportunities to take off to be able to help support their family members that they're providing care for. So it's a whole community of people that's necessary in order to really and truly be able to have the kind of impact that we're talking about. We look at other, we've done a lot of work with housing authorities. We've done a lot of work with transportation systems, so the buses and things like that, and moving, a lot of times the local transportation systems, we're dealing with issues where they're moving bus stops or train stops in communities where a lot of times our seniors and our older adults, that is their mode of transportation to the doctor sometimes. And so, really, it's so important. I can't stress enough, just in the work that I've done with coalitions and other groups, to make sure that all of these people are a part of, all of these entities are present and represented in these collaboratives. Oftentimes you'll see, for example, you may have a maternal health group. It's still important to have somebody in that group talking about, I'm talking about the mother and the needs on the maternal health side, but that mother oftentimes has a parent, a grandmother, a great-grandmother, or someone else in the home with them that needs support and resources. So always looking at things from a holistic perspective in terms of no matter what the topic is, whether it's maternal health, whether it's housing, whatever it is on these community-based groups and organizations, always bringing everyone to the table and really looking at how can we holistically support the entire family, and particularly for our older adults that are in these families, because oftentimes, our older adults and seniors are the backbone for, the rest of everybody else. So it's really important to look at it from a perspective of support and programs and collaboration that's going to provide services for the whole family.
It's not just the healthcare then, it's a whole
That's right.
set of
It's everybody. It's the whole
supportive issues that have
Yes.
to be addressed. Dr. Carlisle, in your opinion, what role do medical education and training play in preparing healthcare professionals to provide culturally competent care for aging individuals from underrepresented backgrounds? So it's not just you met one senior, you met all seniors. There's specific issues that pertain, aren't there, in minority communities?
Yes, and this is why there's a entire specialty in medicine of geriatrics. Medical students need to receive specific training on the elder care requirements in medical education. This is why we offer a course in our medical school called Medicine in Society, because especially for our senior population, there are social determinants of health that impact them greatly. And it can be simply the absence of access to healthy food, the absence of access to transportation, the absence of services, companies that provide supportive services in the home for senior citizens. It's very important for medical students to know how different the healthcare needs of seniors are, simply because they're older. And as you get older, your healthcare needs become more complex. It's important to teach not just medical students, but healthcare providers of every type about this. And so this is why we have specialties within the nurse practitioner profession, for example, within the medical profession, within the physician assistant profession, focused entirely on the care of our older population, a very important component of healthcare education.
But what we just heard from Mrs. Moore was that we need so many other things. You know, the transportation department has to be involved. There are all kinds of units in society that have to work together to support our seniors. And I don't know whether that kind of collaboration is normal. Certainly.
Yeah, it's typically either not present or difficult to engage effectively. It's important when you're seeing a senior in front of you to recognize that they are more than the person that you're looking at. There are all sorts of other components that apply to them, any one of which could have a deleterious impact on their healthcare beyond what they may be presenting with to you in front of you when you're seeing them in your practice. It's important to be conscious of the interaction between these healthcare system components and that patient in front of you, and maybe to ask them, how's your transportation? How did you get here today? How are you getting back home, for example? These things are all factors to be taken into consideration when looking at an older patient, especially from a community that may not have traditional access to factors that many people may take for granted.
Well, it makes it sound as though there needs to be another kind of professional almost who will be in charge of checking all the boxes for that senior. Because that senior, especially if they have health issues, it's hard for them to think of all those different components. You sort of need a case manager that has a list. You know, if it's a senior and she's got this diagnosis, then she has to connect with these different kinds of services in order to make the healthcare services work optimally.
And even patient navigators are an example of another type of profession that has huge benefits to our senior population.
But we don't have that uniformly across systems.
No, they are very much lacking. In fact, I would even say that training patient navigators is a function that medical schools and healthcare institutions serving under-resourced communities should embrace more effectively, including CDU. That's something that we could do more, as could every other health professions institution.
Or the community clinics could do that.
Yes.
Community clinics could change that. Dr. Mims, as the Chief Medical Officer at Rainmakers Strategic Solution, you've likely been involved in shaping healthcare policies and programs. What are some key policy changes or interventions you believe are necessary to improve access to senior care for minority populations?
Well, that really takes me back again to the primary care crisis. You don't have physicians going into primary care for a couple of reasons. One is it costs so much to go to medical school. You come out with a high level of debt that going and practicing in primary care, you may not be able to ever pay off that debt.
Can't
And
pay your
so,
bills.
yeah, and pay off the debt that even is more than what a house costs for you. And so if we had policy changes that made tuition free for those who are going into primary care, and although we have the health services repayment program that pays back like $25,000 for every year that you serve, that's just not quite enough because that's only going to pay off the equivalent of maybe 1 year after you've done it for 4 years. So it's just not enough money in that regard. And so anything that we can do to increase the number of primary care physicians by removing the obstacles of payment would be one part. In addition to that, I chose to go into geriatrics. And going into geriatrics, if I were to be in clinical practice, I would make less than if I stayed in primary care
Oh,
because Medicare pays less for seeing older adults that are more complex, that take more time as they deserve. And so a policy change that would be of value would be to increase the reimbursement rate for seeing our complex older adults who deserve that type of care. Another policy change, we began to talk about people wanting to stay at home as they age rather than going into an institution. And there are home and community-based services that can be covered by Medicaid if you are low income. The challenge is that if mom had paid for a house and she owns the house, but otherwise she's low income, and so she needs someone to do the grocery shopping, someone to come and help her in the morning with getting dressed and going to bed later. Those chores, if they're covered by home and community-based services through Medicaid, after mom dies, the state tries to recoup those dollars. And that might mean having to sell the family home.
mm,
That's a real challenge. So if you're not on Medicaid and you instead use home and community-based services that are provided through the Older Americans Act, there is no need to recoup those dollars afterwards. So there's a major discrepancy here that if you're low income, there's a goal to recoup the dollars.
mm.
But if you're not that lower income, that's not the case. And the last one I would mention, we kind of touched about a little bit before, which is the ability to use family medical leave for caregivers. There's a narrow definition of what a care recipient is that needs to be expanded. It should be also for your in-laws or your ability to support neighbors that you care about. And if you're able to use your FMLA or your family medical leave to be a caregiver for those in need in the community and not risk losing your job because of it, I think we would be able to be more supportive of people being able to age in place rather than spending down and having to go on Medicaid or Medi-Cal in California and going into institutions. People want to be at home.
Yeah. Yeah, where there's more than one person there that could attend to them often. If they're at home, the grandchildren could help and others. There's much more family love in the home than you're going to get in a nursing home in most cases, I think.
A large number of older adults now don't have that extended family. We have not been reproducing at the rate that it had been. And so there are many living alone.
Mm.
And living alone, but still want to live in the community is what needs to be supported. We don't need to have all of those people placed into institutions.
Well, neighbors can take the place of more members of the family. On my block, people take care of one another if somebody's sick. And they're not relatives, they're just people who've lived in the same neighborhood for years and years. And would come to check on you if you were ill. Mrs. Moore, with your background in advocacy and community engagement, what role do you see grassroots initiatives playing? Doesn't have to be medical people, right? Playing in raising awareness about the unique challenges faced by older adults in minority communities and advocating for policy changes to address these issues.
Absolutely. Thank you. And this brings me back, really both what Dr. Mims just said, as well as something that was brought up when Dr. Carlisle was speaking. So you're correct. It doesn't support and grassroots efforts doesn't have to be, perhaps people that are clinical folks. Community health workers are really, really important people in this conversation, because these can be your neighbor, or the people at your church, or someone that maybe works at the grocery store, but they part-time, and they still want to do something to help their community. So community health workers are really, really vital in providing support and resources to our older adults. I've worked with some really fabulous groups of community health workers, and they really take the time to learn what the policies are, to stay up to date on, what's all available to, the people that are in my community that I'm trying to help. And, and oftentimes something else, what they do as well is, when we're talking about policy, CMS puts out, when we're getting ready to, develop a policy or whatnot, there's generally always going to be an opportunity for the public to provide their comments, a comment period, which is open. So we see community health workers, we see different advocacy organizations that will provide their comments to say, and I mentioned this earlier, this is what we're thinking about in the policy framework. But does this really translate to really being helpful when it actually hits the community and it's intended and have the intended results that we want? So I encourage
on the ground.
Right. I encourage, grassroots, community-based organizations, anybody that's interested in really making sure that the policies or the legislation that's put in place that's designed to help. And sometimes in some instances, it may feel like it's a hindrance more than a help. I think that, I encourage people to participate in that process. CMS, it's just too much. There's so many different places that you could go on the website, on CMS's website, and you can find at any given time, a comment period there. But I would encourage people that are interested in really being involved in that way to, just sign up to be on the distribution list for, even your local government or, entities, as well as, federal government programs such as CMS, so that and you can even check off the box of the things that you want to be informed about, so that you don't miss those opportunities to be able to provide comments when when particular policies are coming down that are going to impact those issues that are important to you the most. And especially, when you're trying to do work to help support seniors. So that's one area that I think is really important, that I would encourage people to do that have an interest in doing that. And then I'm going to tread lightly here. But, we also need to make sure that, we're holding all of those people that are elected or appointed or however they got there, to support and advocate for our seniors as well. So I encourage grassroots organizations, are really good at advocating, and they show up and they really, do a lot of work in DC and in other areas across the state to really make sure that the voices of our seniors are heard when they can't be there physically present, but, they're always somewhere advocating for them. There's another organization that comes to mind specifically, that is the PAN Foundation. They have been very instrumental in helping to provide feedback and comments on the Inflation Reduction Act. So some of the provisions that we have they were very instrumental in providing comments around that, because their role is to help provide assistance to people that can't pay for their medication, right? So whenever there's legislation being formed on issues that are important to you, and in this instance, when we're talking about seniors, I really encourage people to be a part of that. And then also, for just like Charles Drew is doing today, and other organizations, hold, teletown halls. Our older adults may not always be able to get out and come somewhere in person, but make it as easy as possible for our older adults to have their voices heard in the conversation. So, holding meetings like this today, holding teletown halls where it's just a telephone conversation, and where it doesn't require you to have to, get on a computer. You can just get on your phone and dial a number and call in. Those are all things that I think are ways that advocacy groups and just your everyday person can really be a part of helping to, support our seniors and make sure that their needs and their issues are raised. I was taking notes when Dr. Mims was talking about, some of the things that she shared as it relates to, some of the programs that I know that HRSA has to help, encourage people to go into primary care. But, again, sometimes things just don't go far enough. So, I appreciate, that feedback. But those are just some of the things that I think are really important, when we're talking about grassroots organizations and advocacy. And, and you can be an organization of one, your voice.
We're all involved in healthcare. But I was just wishing, as I was listening to your list of possibilities, that could be shared with a group of community members who are getting together because they're upset about transportation issues. They're
Absolutely.
not together. You have to go to community meetings where they're meeting on whatever they're concerned about and talk about these healthcare issues, so that everybody gets a little better informed of help that may be available to them, because it's such a complicated thing to take care of health, and you don't always have a family member who's helping you with it. A lot of our seniors just live alone and have to do the best that they can. Dr. Carlisle, as a member of various advisory boards and commissions, what policy recommendations would you prioritize to promote equity in elder care services, particularly in the context of California's very diverse communities?
Well, I think that's a really important question. And I would first of all echo the policy recommendations that Dr. Mims advanced. I think that there are some gaps here in reimbursement for care for our seniors that are kind of low-hanging fruit. In fact, I might even suggest that we kind of have a sliding scale in reimbursement that sort of focuses on our most senior citizens, the most complex cases, to assure that they're able to receive the care that they need, to encourage various types of providers, including those of social services as well, to really focus on that population. Because otherwise, it's often possible to assume that a 95-year-old and a 70-year-old may have, especially from a fiscal standpoint, the same sorts of needs and same sorts of requirements for care, and that's usually not the case. The 95-year-old is way more complex. So I would actually advocate that we start to think about as a possibility calibrating our governmental services, reimbursement services, to the increased needs of individuals as they become not just senior, but more and more senior. Absolutely.
Are we doing that to some extent already, or not?
I wouldn't say to my knowledge that we are, but I would defer to our two other panelists, both representing the federal government and the expertise of the geriatrics profession. I'm not aware of this.
We do have systems where we are in value-based payment systems. if the person is more complex, that there is a higher reimbursement that goes to the healthcare system. And that's great. But oftentimes that increase in revenue doesn't filter down to the level of the primary care clinician who's seeing the patient. So although it may go to the health plan or it may go to the whole institution, that additional dollars that is supposed to help modify the healthcare system, that physician is still looking at 20, 25 patients a day and no difference in the schedule based on how complex the patient that they're seeing is. So that change has not been filtered all the way through.
Yeah, and I just wanted, can I just add one thing to that? Thank you for that. I wanted to mention this, and since we brought up the subject of claims, the Office of Minority Health with CMS is also looking at, and I'm not a claims person, but what's called the Z codes, which is associated, if I'm not mistaken, with the social determinants of health. And this, one of the specific reasons why they're looking at that and why we are also encouraging, more physicians to really, utilize that code is because what we're trying to do is to see, just to your point about, more complex healthcare issues. You may be seeing, Miss Williams for her, diabetes, but perhaps there are several other factors that are happening that she didn't come in or present for. So we're trying to see what are the other factors that are impacting her health so that we can look at it from a claims perspective and see how, perhaps, maybe will be opportunities down the line to be able to, bill or pay more for your more complex people instead of just, what they're coming in specifically for that day. Now, I may not have stated that as clearly as it is intended, but the bottom line is we really are asking and hopeful that we can get more physicians, particularly those that are serving, treating underserved, in underserved communities, to use that code so that we could take a closer look to, kind of the bigger picture and the whole person, and not only specifically just those particular ailments or whatnot that, are being, your claims data is showing. So I just wanted to share that. That's something that we really are aiming to do. So that's, I see you smiling, Dr. Carlisle. So I did the best to explain that, but I do want, I want you to know that that is something that has come up again here recently, and that we are really hopeful that we'll be able to get more information that ultimately will, result in perhaps, different mechanisms for payment for some of those more complex issues.
We can check with Dr. Prothos-Stith and see if we're teaching our students about the Z code. That'd be good to just make sure that they know about that. Dr. Mims, can you elaborate on your experience with interdisciplinary team approaches to healthcare delivery system design, especially concerning improving health equity for minority seniors? How crucial is it to involve beneficiary voices in these initiatives?
Well, I'll take those two separately. One, the interdisciplinary team, and second, the beneficiary voices. So I'm a trained geriatrician, fellowship training, and I did it right after I finished family medicine. And one of the key things that was different was the team-based approach to care. There are parts of the patient who is an older adult that is medical, but there are things that are non-medical. It doesn't need me to be the person to address it. So I really need to have on my team the pharmacist because of multiple medications and the combination and interface with those medicines. I need to have that care navigator who understands the community systems and supports that are there and how to access them and make sure that my patient gets there. I need to have a highly functioning nurse that can do more of that patient education and check back with the patient to ensure understanding and that the caregiver has the things that they need. I need to have a behavioral health person so that not just the patient their care partner, that if there's challenges with coping with the multiple challenges, or if there's concerns about how to involve the family, it may not necessarily be me as the physician to lead those discussions. After I've uncovered them, I can turn this over to my team. Now, this team works best when we're located together, when we can actually huddle each morning and begin to look at who we're going to be seeing that day and decide who doesn't have to come in. We could actually have a telephone appointment. Who usually is late, so we need to send a reminder for them. Who needs to be reminded that they need to bring all of their medications to every visit? Who needs to have a setup for a call with the daughter right afterwards so that we can all be clear on the care. So having those daily huddles for interdisciplinary team is a very essential part of being able to make sure that the care plan is really followed through and that you address those gaps in care. But I did want to go to your other question about
Can I ask before you go to the other part, are all of those personnel billable?
they're not billable. However, and there's a new emerging model of primary care that is going across the country where they're doing value-based care. These are primary care clinics that see pretty much Medicare Advantage patients. And what they're doing is, because they're looking at and caring for older, frailer patients with multiple comorbidities, the reimbursement is higher. And because of the design of Medicare Advantage and them seeing those patients for them and ensuring high quality care, they've been able to get upfront payments at the beginning of the year. They've been able to put on salary these members of the care team and have this whole different design in the way the care is delivered. A real key part of it is that they've been able to drastically shrink the panel size. Instead of 3,000 patients for one primary care physician, it's 400.
Oh, my goodness.
That 400 allows you to see every patient every month.
Hmm.
And when you see every patient every month, you only need to change one thing at a time. And you can see the impact of that change, as opposed to, let me see you now. Let's change this blood pressure medicine, the diabetes medicine. Let me have you do this and do that. And when you come back in about 3 or 4 months, we'll see what happened. That's the standard primary care, and it's hard to get back in.
Yeah.
But in these new care models, it's better designed on an interdisciplinary team approach, and it really rewards quality of care over quantity. And so I did want to go back to that question about the beneficiary voices. We're teaching in geriatrics a 4M approach to care. Number one is their medication. You need to review every medication every single time you see them, because other people are prescribing other than just you, and you need to look for those drug interactions. If a person comes in with a new symptom, look at the medicines first. Often it's a side effect. Number two, mentation. Are they starting to have challenges with their memory, their behavior? That's something we need to regularly look for, because unfortunately, when we're not screening for it, we can miss that people are declining in their ability to care for themselves. And the first time we realize it is a crisis hospitalization. Third M is mobility. Is a person able to be safe in their environment without falls? Do they have the necessary equipment to maintain their independent mobility? And the fourth M, which is most important, is what matters most to the individual. What matters most? So when you were in your 82 and you have 5 different medical conditions, and we have guidelines for all of the type of care that would be appropriate if you only had one condition and you were 50 years old, but instead you're 80 years old and have multiple conditions that would call for 13, 14, 15 medications. I need to know what matters most to you. Is it quality of life? Or is it taking all of these medications? Should you have that colonoscopy as a follow-up from 5 years ago because you had a polyp 20 years ago? Maybe not, because if I find something, are you really going to want to have surgery? No. So when we look at what matters most, we can begin to focus guidelines-based care to individual person's preferences based on the time that they have and what they consider quality of life. So we have to listen to the person. There's a saying, I don't remember where it came from. Nothing about me without me.
Mm,
Make sure my opinion is part of the conversation.
mm.
Thank you.
That sounds so wonderful. I just, I think patients would love it so much if they had just that kind of quality conversation with their provider. Usually you just don't get that much time to go through that kind of tailored conversation about this person in front of you and what's going on in their lives. That's a wonderful objective. Mrs. Moore, Jackie says we have to start wrapping up. Mrs. Moore, let me ask you this last question then. How can initiatives like the Inflation Reduction Act contribute to improving access to essential healthcare services for aging populations, particularly in minority communities where financial constraints often pose significant barriers?
Thank you. Thank you. So the Inflation Reduction Act, really, whenever I talk about it, I always say it's good news, good news, good news. And I'll just, for the sake of time, I'll just give you a couple of examples of why. So particularly for communities that are underserved or, have financial barriers, one of the key provisions of the Inflation Reduction Act went into effect in January of this year, and that is the expansion of the Low-Income Subsidy Extra Help program. And what that does essentially is that it removes deductibles and copays for your Medicare Part D prescription drugs. So that means you pay nothing. You don't pay deductible, you don't pay any of those copays, any premiums anymore, because if you qualify for the Extra Help program, then you now are eligible for this benefit now. So it's really exciting for a lot of people. It saves money for so many of our older adults that, oftentimes make the decision between, am I going to get my medicine this month, skip next month, and then I'll get it the next time because of financial constraints. And then the beauty of it is also anybody that was on partially eligible for the Extra Help program or the low-income subsidy. So some people were already fully getting it. Now, if you were even partially eligible for it, now you're fully eligible. So basically, that was expanded to cover those groups of people as well. So that's something that we're really excited about. We've talked a couple of times and used diabetes as a reference point. $35 cap on insulin. Medicare covered insulin is something else that is, a huge cost savings for a lot of our older adults and that use insulin. And that's not just one insulin. I didn't know that people could take more than one type of insulin. So that's for a 30-day supply, $35 cap. So that's another bit of good news as well. And then certainly the expansion of the coverage of all of your adult recommended vaccines. Particularly, we always want to point out the shingles vaccine. That is now at no cost to people.
Oh, that's terrific.
Under their Medicare, yes, under their Medicare Part D, because, and so that, those are just, a few. There are several other benefits, and we're moving to also, the new program that'll be coming out in 2025. So you guys listen for it, which is the Medicare Prescription Payment Program. That's going to, not everybody is going to be, it's not going to make sense for everybody to take advantage of this, but for people that have very high cost prescriptions, then they will have an opportunity to work with their health plans to, instead of paying that out at the point of sale, to pay it out over the course of the year. So that also is going to bring a lot of cost savings for individuals that have really, really high prescription drug cost. And I think, let's see, I think that those are like some of the, and I can't leave this and then I'll close there. The negotiation of drugs that CMS is doing right now with the pharmaceutical companies. So we started with 10, and that's going to continue to gradually go up to 15 to 20 and so on and so forth. But we started with 10 of the most used and the most costliest, the ones that have the highest expenditures that have been used by people on Medicare. So that includes, your diabetes, so Jardiance and Farxiga and some other medications that are specific, Exalto, and others that treat not only diabetes, but treat heart conditions, treat blood cancers, and a couple of variety of different chronic illnesses. So those also are in the negotiation phase, and we're excited that the pharmacy companies agreed to negotiate with us, and those cost savings, whatever we end on, will be passed on to our seniors. So those are just a few of the key provisions. There are several others, but I just want to really be able to highlight those. And thank you for asking about that. So we're excited about that.
This is such valuable information. I'm so glad this conversation is being recorded, because not only the people who are listening today, but the future people who can click on and listen to each of you describe, what the state of support is out there, where it is working, where it's been improved, and where we still have more improvement to go. Dr. Carlisle, let me ask you for the last comment. Looking ahead, what do you envision as the ideal state of elder care provision in communities of color, and what steps can stakeholders take to work toward that vision?
Well, I'd like to see a real unification of disparate service and care strategies. We have clinics like the PACE clinics or social HMOs that are doing this. We need to have more of them. And, I think that we can get there. I think that we need to focus on the special needs of elderly individuals in under-resourced communities to make sure that they are not suffering disproportionately. We need to look into things like even elder abuse as a significant issue. So I think just having awareness of this and bringing it to the education, not just of medical students, but all of our health profession students, is a major step forward. And we need to make sure that we're continuing to focus on the policy needs of this population as well. So I think that we're making progress, and there's clearly a lot more to be made.
Well, I'm sorry that I've got to bring our conversation to a close, but this has really been so rich and enlightening. And on behalf of the university and our students, I really thank you so much for your time and sharing your expertise and experience with the listening audience. And I want to thank the members of the audience who listened today, because I'm sure they learned a lot, and I'm sure that they were wishing that you would each be their providers wherever they are, because you're so caring and so knowledgeable. This is an important dialogue, and we're grateful that they could hear it. Please share and interact with our forum on social media by using hashtag CDU Community Forum for people that you're in touch with, so that they could listen to this conversation also. Okay, so let me just thank you again, and please tune in for our next discussion. Thank you, thank you, thank you.